Welcome to Wellness Wednesdays. I'm Mollyann Allen. I'm one of the physician assistants here at Norterra Family Medicine. Today, we have a very special guest talking to us, Dr. Scott Gulinson with Thunderbird Obstetrics and Gynecology. Dr. Gulinson is a board-certified obstetrician and gynecologist. He has delivered thousands of babies. He's done thousands of gynecological procedures. He is a beloved doctor in the community, and all of us here at Norterra refer to him frequently, and he's always been an advocate for our patients and so helpful. So we're so excited to have him here with us today. Today, we are going to be discussing birth control options for women. So thank you so much for being here today.
Yeah, thank you for having me.
Welcome. So there are so many choices for women these days when it comes to modern contraception. I'm excited to discuss with you some of the good oldie standby birth control and some of the new trending modern options for women. So yeah, so I'm excited to get started.
Cool.
Do you want to tell us, maybe start off with some basic anatomy and physiology in relationship to birth control options?
I can. Actually, I have a little pelvis here that I brought. Are you able to see that very well?
Yeah. Yes. Nice.
Pretty good. Okay.
Yes.
So
Look at that.
Usually will use this when I'm in my office to talk to people about almost anything, birth control or fertility or surgeries or anything like that, because it's very, very handy. So basically, if you can see this,
We can.
this is the vagina. And then this is the cervix, the uterus, the urethra, and the bladder, pubic bone. And then if you can, and then here's the rectum. And then if you look from this top down, let's see if that'll show up. You can kind of see the fallopian tube and the ovary on each side. Trying to do this upside down here in your camera, so sorry if that looked funny.
No.
You can see that, so that's basically that. And then we can break this open here, and I can show you this person. Oops, cut in half. So this pink lining in right here is the endometrium. Okay, so basically what happens is the ovaries are going to use hormones in order to control the thickness of the endometrium. The ovaries are going to receive their signal to do that from the brain, from the hypothalamus and the pituitary gland. So those are going to make gonadotropins, LH and FSH hormones. And they're going to talk to, try to keep this all together, they're going to talk to the ovary on one side 1 month, the other side on the other month, to start recruiting follicles. And the ovary has all the eggs that a person will ever have from birth. So they don't make any new eggs. They already start with their full supply. The ovary is going to recruit follicles. Each follicle has an egg in it, and it'll select out a dominant follicle according to the hormone timing. It is under the influence now, the ovary is under the influence of creating estrogen. So the estrogen that the ovary creates while it's developing follicles is going to cause this inner lining of the uterus to start getting thick and plush and ready for pregnancy. Once a follicle becomes a dominant follicle, gets to be about 25 millimeters in size, an LH surge happens from the pituitary gland, and that causes the follicle to rupture. And the follicle, when it ruptures, it's going to release an egg, and that egg is going to be picked up by the little fingers of the fallopian tube called the fimbria. And so they surround the egg, they pull it into the tube, and inside the tube are little hairs that are kind of pushing along the egg in order to encourage it to travel down the fallopian tube and into the uterine cavity. Okay, so it comes out around here on the side, and it's looking to implant here as an embryo, as a conceptus. So essentially, once that LH surge happens and it's ovulated, the ovary now starts making progesterone hormone. And the progesterone hormone while those things are going on with the egg developing and coming out, progesterone is going to cause this to strengthen. It makes like a lattice work inside the endometrium lining, and that gets it ready for implantation. So it doesn't just become unstable and start sloughing off. So if it becomes unstable and sloughs off, there's nowhere that's good for the implantation to take place. So progesterone will be secreted from the ovary, get this ready for implantation. And then if your body discovers that you did not get pregnant, the progesterone from the ovary shuts off. The lining here doesn't get its hormone signal any longer, and it basically degenerates and falls out and starts sloughing off. And that's when the menstrual cycle starts. And then the whole thing starts again all over again from the other side with the hormone surge and the development of the follicles and the dominant follicle and the estrogen thickening the lining of the uterus. The ovary makes its follicle about 24, 26 millimeters in size, pops, releases the egg, which travels down. And then the progesterone gets everything ready. And if it doesn't work, then everything sloughs off. So that's kind of the menstrual cycle 101 and the important anatomy for that. So you can kind of talk about this kind of stuff for fertility, for helping people get pregnant, for talking about the menstrual cycle to people so that they understand that. But that also helps to understand how birth control works. So if you figure, what could you do in order to prevent pregnancy? You could block sperm from meeting the egg. So if you block sperm from meeting the egg, you're going to have to talk about things that are barricades so that the sperm can't get through. So here's the vagina. So if sperm are deposited here, they're going to go into the uterus and they're going to start swimming up the uterine cavity. And then they go into both fallopian tubes. And if they're successful, conception occurs right here in the middle ampullary region of the fallopian tube. So once conception takes place, it starts developing into a blastocyst, an morula, and it starts tumbling down into the uterine cavity, and hopefully, or not, it implants into the uterine cavity and pregnancy starts. Or if it fails to do that, or if it implants onto a polyp or a fibroid or a septation in here, and it's not a very good source of blood supply for pregnancy, then it might start a pregnancy and then fail and fall out, and that's where miscarriage basically is. Okay, so if we want to prevent pregnancy, contraception, you can do that with preventing the sperm from meeting the egg by blocking it. So obviously a condom, first of all, or a sponge with spermicide in here can block them and can kill them with spermicide. Or a cervical, whoops, there goes my uterus.
That's one way.
That's one way, take the uterus out. So a cervical cap will block them, or a diaphragm that goes inside here will block them too. Those are not very common methods of birth control any longer. Not a lot of people ask for those. So once you have the non-hormonal ways of obstructing the sperm from getting there or killing the sperm with the spermicides, you can talk about ways to block ovulation, or you can block them from meeting by sterilizing, by blocking the tube here. I'm going to take this out so you can see my uterus better. There, is that better?
It's so much better. Yeah.
So you can block the tube. So that's what sterilization is by sealing the tube shut, or removing a portion of the tube, or removing the tube altogether, or taking the fimbria off. So those are all different ways of sterilization. So if you can block ovulation, in order to block ovulation, you have to do that with something that's going to be systemic. So you have to have something that's going to be able to get to the ovary, and that's going to have to go through the bloodstream in order to talk to the ovary, right? So the ways we have of doing that are going to be your birth control pills, your Depo-Provera shots, your Nexplanon, that sort of thing. Okay, so basically there's lots of ways to do that. And most of the hormonal ways, well, all of the hormonal ways of birth control, do something with the estrogen and progesterone, one or both, in order to help kind of alter this and make it so that your body thinks that there's enough estrogen or progesterone in a system, and it blocks that surge of hormone communication onto the ovary. So the ovary doesn't really get the message that it's supposed to recruit these follicles, develop a follicular cyst or dominant follicle, or rupture or any of that, right? So that's kind of in a nutshell how birth control is going to work, whether it's a systemic birth control, a hormonal birth control, mechanical blocking, that sort of thing. Okay, so there's condoms, there's blocking of ways with a cervical cap, there's a diaphragm that blocks it as well. And if we do hormones, we need to do something that's going to be, sometimes what I'll ask people is, well, what do you, if you're going to choose like hormone birth control, what do you want your menstrual cycles to be like? Because some people want to have a menstrual cycle, some people don't want to have a menstrual cycle, some people want to have it sometimes and be able to control it and not have it at other times. So you can do a lot of things with birth control in order to manipulate the cycle timing and that sort of thing. So most of the time, people will want to have something like a birth control pill, which is probably the most common birth control method. So here is an example of birth control pills. So all birth control pills are going to have an estrogen, a progesterone, or just a progesterone in it. I don't know if you can read that or not, but this says the two hormones there. So this one's got levonorgestrel as its progesterone, and most of them are going to have some like ethinyl estradiol. Most are going to have that, but there's some new ones that use a different type of estrogen. So this one, and then it'll say on the bottom here, how many milligrams of each hormone there are in each pill. And so if you figure, if you can adjust what type of progesterone, what type of estrogen, and then how many milligrams of each hormone you're using, you can come up with thousands of different types of birth control pills. And so that's kind of what's happened. We used to have hormonal birth control with an extremely high level of estrogen in it, and discovered that there were a lot of side effects from that. So we now have birth control, used to be 50 micrograms. Now we have birth control with 20 or even 10 micrograms. So very low hormone doses. You can, here, I'll open this so you can see this. A lot of them will come in a pack like that, so that you can hold on to them or hide them. And then they will have, let's see if I can get this so that you can see this pretty well. But basically, there we go. See that? So there's going to be in a monophasic pill, which means it's got the same dose of the hormones every single pill. They're all going to be the same color. And so if you see where it says start right there, and you go that way on this pack, I usually have people start on like the first Sunday after they have a menstrual cycle, because the lining is nice and thin. And that way there's not a lot of endometrium lining to slough off. So the potential side effect of irregular bleeding when they start the pills are less. So I usually have them start here, and they take their first week, second week, third week, and fourth week. So the fourth week always has a different color, because there's actually not any hormone in these pills in the week here. Some will have 7 days, some will have 3 days, some will have 4 days. And the purpose of these pills is really just to keep you current in taking the pill and remembering to take the pill. So you make it a habit, but there's not actually any hormone in here. And that's going to make it kind of like what happens when the progesterone turns off from your ovaries. The lining of the uterus is going to shed. So as soon as you get to these pills here and the hormones have shut off, it's sort of pretending to do what your ovaries and your hormones were doing. It's going to make you have a progesterone withdrawal bleed, and that's going to be your menstrual cycle right here. So it takes usually 2 or 3 months or so for your body to get accustomed to taking these pills. And once you do that, you should have pretty regular cycles. They should occur during these blue pills here. And then when you take these pills, there's 7 of them, you get to that one, you automatically get your next pill pack and you start over right there. And the good thing is you should have a label across the top. So let's see, like this was Tuesday's pill. but here it is on Wednesday, and you're like, oh my gosh, I forgot Tuesday's pill. Well, you just forgot yesterday's pill. You can take yesterday's pill, and then you can take today's pill and sort of double up in order to catch up a little bit and continue on. Now, if you do that too many times, it's not going to be effective as birth control. And it'll do this. It'll make your body think that you stopped taking the pill. So if you keep doing that, you'll eventually have bleeding that's irregular and hard to control. So you have to make sure that you take them every single day. These ones aren't so sensitive that you have to take them at the same time every day. You just have to take them every day. And so you want to make sure also that you don't take any kind of medications that might affect these or might interrupt these or might block their metabolism to make it so they're less effective. So if you wanted, you could actually use these also to control your menstrual cycle. So let's say you're on your pill and you want to go on a vacation to Cancun and you really don't want to be having your menstrual cycle when you're on vacation. And so what you can do is once you get to your last pill over here, you can throw these pills out and start your next pill pack up right here. And that way you've taken them in a continuous fashion. So you'll miss having this menstrual cycle because you won't give yourself a withdrawal bleed. And you just start up with the next menstrual cycle here. So sometimes we'll have people do that for 1 month or one cycle. You can actually do that up to 3 cycles in a row if you want to. But I don't really recommend going longer than that because then you can thin the lining of the uterus out so much that it starts just sort of spotting and irregularly bleeding. So the best way to do this is 2 or 3 months in a row like that, and then have a menstrual cycle. So you can imagine like if some people have menstrual migraines or they have endometriosis, and this is helping control it, but they always get their menstrual migraine here, or they get their endometriosis and pelvic pain here, they can use these and manipulate their cycle a little bit to control those other issues and not have their menstrual migraine or not have their pain or whatever. So very useful, very effective birth control. But
yeah, I have quite a few patients that will do that if they are tend to be have menstrual migraines and things like that. Or
because a lot of times menstrual migraines
nice.
happen because you have such a drop in the hormones. It's a sudden drop in the hormones that give you the menstrual migraine. So if you don't drop the hormones and you just keep taking them, then a lot of times it'll help prevent that. And birth control pills are metabolized in your liver. So if you ever heard of anybody getting a blood clot on a birth control pill, most of that's because when they're metabolized through the liver, they're activating the clotting hormones and proteins, and that can increase the chances of blood clots. So you always have to be careful. Like if you have a history of blood clots, you can't take these. If you smoke cigarettes, that increases the chances of a stroke when you're on the pill over the age of 30, so you can't do that either. People with lupus can't take estrogen, so there's some people who are not good candidates for taking birth control pills. If you have somebody who can't take estrogen, there are some birth control pills out now that are just progesterone. So there's one called Slind that's got drospirenone in it. That's progesterone only pill, very effective. And the drospirenone has a little bit of a kind of like a diuretic effect. So it can kind of help with bloating and it can help with fluid retention and that sort of thing.
Yeah.
Or somebody who is nursing a baby and they don't want the estrogen because they don't want to risk decreasing their breast milk. You can take a progesterone only birth control pill for that. But that's only as good as combination. This is a combination pill because it has both the estrogen and progesterone in it. So the progesterone only mini pills are only as good as these if they're breastfeeding as well. So if they're breastfeeding every 2 to 4 hours, I'll put them on a progesterone only pill for birth control. So that's a good way to go. And then a lot of times they're, if once they get to a point, if they're breastfeeding less than that, if they're only doing it like twice a day and the rest of the time they're bottle feeding, then I usually try to switch them over to a combination pill so that they can get effective with this. Now, obviously.
So you said if they're breastfeeding, how many times a day?
I like them to be breastfeeding about every 2 to 4 hours during the day. That doesn't mean they have to wake up at 4 in the morning to breastfeed for this to be effective, but every 2 hours to 4 hours during the day, a progesterone-only birth control pill should work just fine. Technically, once they have established breast milk production in about 3 months or so, it shouldn't reduce their breast milk very much to take a combination pill, but it's possible. So I usually just use the progesterone one in them.
Okay.
Okay, obviously these do not protect against any STD whatsoever, only pregnancy. And they're good for other things like pelvic pain, preventing ovarian cyst formation, because these act by blocking the hormone stimulation on the ovaries. So they act by blocking your ovaries' ability to make a follicle or make an ovarian cyst. So if you have somebody that has ovarian cysts already, and you want to kind of see how they're doing, get rid of some of their pain, maybe block the ovary from making an ovarian cyst again. This is kind of helpful to block the ovaries down, shut them down while their body's kind of trying to get rid of a simple ovarian cyst or follicle that's misbehaving. So useful for lots of things, right?
Right.
So then you can do progesterone only birth control. So that would be like your shots, and that would be like your capsules. So we used to have something called Norplant, like years ago when I was just starting, people had Norplant, and that's when it was getting kind of a bad name. But the Norplant was 6 capsules of progesterone, and they were inserted under here. So you'd have like an array of like 6 capsules under here, and they were pretty small. They were like maybe that big and about this wide. And so when I was starting to train, a big part of one of the clinics I went to was taking out Norplant capsules off of people, and it was kind of a pain. But they got better with this, and they came up with same kind of idea with Implanon and then with Nexplanon, which is a progesterone capsule. It goes under the arm, usually put it right about there. And it's good for 3 years at a time. So that is going to be progesterone only. It gives you a certain amount of progesterone in your body. The progesterone blocks the communication of the hormones, LH and FSH, by dropping them. And so they can't tell your ovary to make a follicle or recruit any eggs, or it blocks it from being able to do that. So that's another way of blocking ovulation, is to have enough progesterone in your circulation. So Implanon or Nexplanon now is a good way to do that. The problem with Nexplanon is that we have to put it in the office. And so if we're making we don't really make an incision there because it's really just a large, like 16 gauge needle really to put it in. But to take it out, you have to make a small incision here and numb it, and then you can pull it out. It's got to be very superficial under the skin. Very rarely can it get lost in the crevice here or even up in here. There's been some case reports, but that's really pretty rare. So nice birth control. You don't have to do anything. You don't have to remember anything except for the fact that you have it there. Most people seem to like it a lot. Small chances of things that are side effects, like some headaches or discomfort in this area. I have a couple young ladies who are cheerleaders, and if they get their flyers for their team and their team catches them right here, and they've got a little capsule right here, so it can be a little bit uncomfortable. But basically the way that the Nexplanon acts is by a constant level of progesterone in the circulation. It goes everywhere. So it's not just the ovary that it's talking to, but it's the ovarian receptors that have it, that it reacts for there.
Is there much breakthrough bleeding with that?
So interruption of your menstrual cycle. So that's a possibility. I have some people that have regular menstrual cycles when they're on the Nexplanon. And I've had some people with light spotting all the time. And so, like I said, when I talk to people about birth control, a lot of times the first thing I ask them is, what do you want to have happen to your menstrual cycles? And what kind of convenience factor are we talking about? Some people can't remember to take the pill every day, but they like having a menstrual cycle every month. And so you have them put it next to something that they do every day, like hopefully they brush their teeth every day and they can put the pill pack next to their toothbrush. But some people just can't remember to take pills. They're terrible at it. They forget, and they'll just have irregular bleeding. So they want something that's convenient from that standpoint, that you don't have to remember to do anything. So the Nexplanon's nice for that. So that's 3 years of birth control. But yeah, you can have some mild headaches with it. Some people have reported a small amount of weight gain with progesterone birth control. If you have a history of depression, there's a small increased risk of depression exacerbation with progesterone birth control, and then an interruption of your menstrual cycles. So could happen. Depo-Provera is kind of like a bigger brother dose of that. So Depo-Provera is an every 3-month progesterone shot does the same exact thing, but you have to get the shot every 3 months. It's intramuscular. There is a version that's a subcutaneous version of it. It's not very common here, but there is a subcutaneous version of Depo-Provera. I think it's more frequent than the 3-month shot.
Mhm.
So same thing's going to happen. It's a depot muscular injection that stays there. It gets picked up by the capillaries. They take the hormone through your blood circulation, and they communicate through this hypothalamus pituitary axis with your ovary of blocking that whole feedback cycle. And so they sort of obstruct your body's ability to make the ovarian follicles and to ovulate. They can thicken the cervical mucus. That's another thing that your body can do to kind of make it harder to get pregnant, is have thick cervical mucus. They also keep that lining inside the uterus at a pretty thin stretch. So I'll have some people where maybe they're having a lot of problems with bleeding, and we might try a Depo-Provera shot in order to kind of shut down how much bleeding they're having, because that can be effective in controlling how thick that lining, the endometrium lining is. Really good birth control, probably the best birth control that there is, maybe even better than tying your tubes. 99.9% effective if you do not miss your shots. It's good for people with a seizure disorder because it's going to block their seizure potential. So that's a really good way to go for people with seizure disorders. But it is every 3 months, and the side effect profile is a little stronger than the Nexplanon and a little stronger than the birth control pills. What else can I tell you? Also, tie-in tubes. So if you wanted to absolutely never, ever, ever, never, ever get pregnant again, then you'd want to go something like sterilization, surgical sterilization. So we can tie the tubes, which doesn't really mean we're tying them. We're just blocking the tube. We're blocking the ability for the sperm and the egg to meet inside the tube. Now, you can do that by melting it, putting a clip across it, or removing the tube altogether. So all 3 of those require surgery. We used to do a procedure called Escher. And Escher was a titanium and nickel coil that you could put in the office, really. You could basically go into the uterus up to here and place it right where the tube comes in. And those coils would go right at the entry between inside the tube partially and inside the uterus partially. And they would stimulate this to kind of grow into the coils. And that's how they got birth control, is they were blocking this. It's actually been taken off the market now, and I have some people.
I didn't know that. I didn't realize it wasn't on the market anymore.
Yeah, they're off the market now. They had some people with complaints that had nickel allergies and were getting some very bizarre symptoms, rashes, hair loss, joint aches, muscle aches. And so I'll have some people call and want to have these taken out, which is not the easiest thing in the world to do, but it can be done.
Okay.
So you'd have to have surgery in order to take those out. So then there's intrauterine devices. So intrauterine devices are exactly that. They go intrauterine. And there's 2 basic types of an intrauterine device, with hormone and without hormone. So I have a without hormone intrauterine device here. So this, you can see this, that's a Paragard. See that?
Yeah,
so
with the copper, right?
So Paragard is copper. So all IUDs, there's the IUD, it's a shape of a T. It's got a ball right there. It has a little string that hangs out. So here's your uterus, cervix, string hangs out of the cervix. I usually cut them about 2 to 3 centimeters so that they'll wrap around the cervix and get out of the way, so she and he don't complain about feeling poked during intercourse. This should fit just like that. If it doesn't, if it's sideways, or this arm folds, or it pokes into the uterus, or when somebody does put it in, they can perforate the uterus when they put it in, or they can put it too low. So there's some things about placement of an IUD that you have to be cognizant of doing. Some people do it under ultrasound guidance. I don't really do it under ultrasound guidance. I feel like I can feel it well enough in order to put it in the right spot. So this one is Paragard. It's good for 10 years at a time. It's made of copper, and it's going to act by causing an inflammatory reaction inside the entire cavity of the uterus. So if sperm are trying to swim up, they're going to not like this kind of reaction that they're receiving very well. If by chance they did get through and they did get into the tube, and fertilization did happen, and then the egg and the sperm come back, and they try to implant. They really can't implant into anywhere healthy because of the inflammation inside here. So it's not a very warm, welcoming environment for things like that. So, but most of its function really is creating this kind of inflammatory response in here. And it usually impacts the sperm swimming through. This has been an issue as far as from the anti-abortion standpoint, because is that an abortion then? If you have conceived in here and it's coming down and it blocks the conception, some people feel from that side of the argument that that's causing an abortion. So that's met with some issues from that standpoint. The other IUDs are all made of progesterone. Again, progesterone can thin this lining. And so the progesterone IUDs act by thinning the lining. So it's not really a good cushy place to implant. It's not going to really let these sperm swim through. So there's Mirena, there's Liletta. They're exactly the same from two different companies. If you want to get something for like a teenager, there's the smaller applicating devices and the smaller dose IUDs you can use for someone who's a teenager and doesn't want to worry about their cycles and doesn't maybe have a good ability to remember to take a pill all the time, and they're worried about weight gain with the Depo-Provera. So sometimes a small 19 milligram IUD is nice for them instead of the 52 milligram ones. So smaller applicator, it's easier to get into a nulliparous cervix than these bigger ones are. So there's IUDs. And then there's other versions of the pill. So I have there's a NuvaRing, if you ever heard of a NuvaRing. So birth control pills are good because they can be taken orally. Well, you can absorb hormones vaginally or through your skin. So this is a NuvaRing, and NuvaRing also is made with progesterone and estrogen. So there's the same thing, just different kind of progesterone, but ethinyl estradiol. And in this squishy little ring, that's where the hormones are. So basically that goes inside the vagina. This really is helpful in teaching that to people, because basically if you squeeze this, it goes very easily. It pops open. Now that I took this whole thing apart, but it pops open nicely. This is not a barricade. It's not you don't have to worry about what position inside the vagina this goes. Once you squeeze it, you push it in, it pops open, and it orients itself in the anterior vaginal wall. So it's out of the way. So when people come in, they should not know that they even have this in. So some people have to mark on their calendar that they have a NuvaRing in and they need to take it out. This is only good for 3 weeks in a row. So you can place it in right out on a Sunday or Monday after your menstrual cycle, put a NuvaRing in, leave it there for 3 weeks. Your alarm on your cell phone goes off. I got to take this thing out. It's very easy to get out. You just push your fingers in the vagina, hook around it, pull it. It's so soft, it'll just pull out. It shouldn't cause any scratching or scraping or anything like that. I've had people come in for their annual exams before and they have this in and you can't even tell that they have it in. So it's out of the way. Shouldn't bother people during intercourse. It's not going to pop out or anything typically. But if it bothers somebody, you could actually take this out for 3 hours, have intercourse, and put it back in if you were so inclined to do that. You don't really have to. You're not going to notice that it's there usually. There's a bigger version of this. I think it's pretty new. It's called Anova, I think. And instead of getting an individual one like this and throwing it out at the end of the month, it's actually got all the hormone you need for about a year.
I have not heard of that one.
Yeah, so you squish it down, you place it inside. After 3 weeks, you take it out, you wash it off, and you put it in this little case. And then you have your menstrual cycle week, and then you put it back in.
What was it called again?
It's called Anova.
Okay.
I hardly ever use it. I hardly ever have anybody ask for it. You always have to is the insurance company going to cover this or not? So you always have to play with them a little bit because of that. But you can do the exact same thing with your menstrual cycle with this. And you can place this inside for the 3 weeks. If you don't want to have a menstrual cycle because you're on vacation, you take it out because it's now empty of all its hormone, but you take your next one and you put it right back in for the next 3 weeks. So now that's 6 weeks in a row, and you can take the next one out, put the next one in. So that's 9 weeks in a row that you could actually go with avoiding. So I put my model back together so you can kind of see how this new ring goes in, right? So what I usually tell people is the best way to do this is to stand with one foot like on a chair or something, and then push it down like this. So your face like that, it goes inside. And once it's in the vagina, it just pops right into place, okay? Now, a lot of times it'll actually end up there, but it depends on where your cervix is in relation to some of these other structures. So usually it just goes right in just like that. And as long as it's touching the vaginal walls, it's going to release its hormones into the vaginal walls continuously. So it does as much as it needs to do. It's a controlled fashion release of the estrogen and progesterone. And so again, it gets into the bloodstream, and then it's going to block communication to your ovary from making its hormones, because it has its own hormones. So it's going to exert on the endometrial lining what it needs to do to keep that thin, so it's not really going to be ready for pregnancy. But when you take that out, there's no hormones anymore. There's no estrogen and progesterone, and whatever is in there on the endometrial lining to shed will shed. So the lining usually sheds, and there's usually like less to shed from. So this is another good way of controlling menstrual cycle heaviness and duration.
Mm-hmm.
If you didn't want to have it for a vacation, you could just put the next one back in. So all these are good for helping to kind of reduce menstrual cycle flow and birth control, but not STDs. These have nothing to do with that. And then the last birth control thing that is out there that's cool is the patch. So you can have, I didn't bring a patch today, but there's one that's about this big. There's another one that's about that big. And with the patches, basically, it's the same thing. It's going to be an estrogen and progesterone, and it's in a patch that's this big. And you do not want to put it somewhere like that's getting sweaty, or it's going to be rubbed by, you know, clothing or a bra or an elastic strap. So usually people will put it maybe like back here away, or they'll put it back here. I had somebody put it on their ankle, and it's not a good spot. So you can't be so far away from your main sources of your vascular supply in your body. So putting it on your ankle doesn't work, but you can put it like, you know, I mean, I guess you could put it on your thigh if you wanted to, but that's going to rub on your pants all day long. So most people will put it like right here or right here, maybe like on their back or something like that. So that's a good place for that. So those patches are only good for a week at a time. So each box that you get with the patch, it'll have 3 patches in the box, and it's going to be kind of like that NuvaRing. It's good for 3 weeks, but you have to change that patch each week. And the problem with the patch is that some people react to that adhesive, and they get like a little square, red square on their body, or they get a little itchy, or if it falls off, it's not effective. So a lot of people, what I'll tell them to do is get like some rubbing alcohol wherever you're going to stick it, rub some alcohol, rubbing alcohol on that so it's clean and it's dry and it removed whatever lotion you might have put on, and then you can stick it on there and it'll usually stay longer and fix longer. But after that 1 week, you got to peel it off and put the next one on. So usually you have your menstrual cycle, the first Sunday during or after. So maybe like Monday, stick it on, following Monday, peel it off, stick it on, next Monday, peel it off, stick it on, 3 in a row, and then peel it off so you can have that week of menstrual cycle timing, and then put it back in. So it's doing the same thing. It's systemic hormones, and it's blocking your ovulation. It's affecting the lining of the uterus, and these are going to kind of thicken the mucus in the cervix too.
Would you say, like in general, like what is like very popular in younger women, and like what is very popular in like 30 to 40-year-old women versus 20-year-old? Is there like a trend, or is it all over, just very individual?
Really, I mean, I will say probably the pill is still probably the most popular method of birth control. It's convenient, it's easy to control, you carry it with you. But you know, if you get side effects, and so I usually tell people there's so many different pills on the market right now that it's kind of like going to a shoe store and trying on shoes. So you figure out which one has what side effects to it, and you decide, well, you know, it's a side effect, but I don't really mind it that much. It doesn't bother me that much. I'll tolerate it. So if doing the pill is what you want to do and you take one and you notice that that one's giving you some headaches, then maybe switch to another one. Maybe you get breast soreness and switch to another one. Maybe that one made you a little nauseous or emotional lability. But there's so many of them, you can switch around and try different doses of the estrogen and the progesterone. Or you could do a triphasic, which each week has a different dose of either the estrogen or the progesterone. And if that's just not going to work, you can just go to the patch if you're getting stomach aches from the pill, or you can go to the NuvaRing if you're getting the rash on your stomach. But going from the pills to a completely different systemic progesterone, you got to be prepared for the side effects of the menstrual cycle. So depends on what you feel about your menstrual cycle. Some people have to have it. They feel more comfortable that they're having their cycle. They'd rather make sure that they have a regular cycle each month. And that's the pill, the patch, or the NuvaRing. If you'd rather never have a cycle again and you like the fact that you can go a long time without it, that might be the Depo-Provera. If you want a temporary birth control pill and you want to get pregnant maybe in a year or a year and a half, don't use the Depo-Provera, because the longer you're on Depo-Provera, the harder it is for your body to get back to having its normal hormone mechanisms and back to being able to ovulate. So if you want to get pregnant in a year and you use Depo-Provera for a year, it's probably going to take you a year before your body starts really regularly ovulating in a predictable fashion again. So I don't like to use Depo-Provera in people that are anxious to get pregnant soon. Same thing with the IUD. If you think you're going to get pregnant next year, why put in an 8-year IUD or a 10-year IUD? They're expensive if your insurance company doesn't cover them, but they're not expensive if you figure that's for 8 years of birth control. It's not so bad. But if you use it for a year, kind of a lot if your insurance doesn't cover it. They have a lot of other benefits, acne control, a lot of other things you can do with them.
But there are a lot of choices.
Yeah, there are.
Yeah.
I mean, but usually you can kind of simplify it. You know, if you have a teenager who forgets to take things all the time, usually I'll have teenagers come in with their mom or their dad sometimes. And this is kind of stuff you go through is like, what do you want your cycles to be like? Do you want to try to get rid of some acne? Do you want to, can you remember to take a pill every day? If you sort of come at it from that perspective, it's easy to offer what might work the best for that circumstance. So you can take these pills like perimenopausally too, as for some hormone regulation right before menopause starts. So not a bad way to go from that perspective too. So yeah, lots of options. So there's new ones coming out all the time. Probably have a new version of a pill or something, and that's a different kind of hormone. And every couple of years or so, we'll have some brand new, type of estrogen that comes out that they're using. And Nextstellis is a good one. They just came out with that. That's been pretty helpful and effective. So, problem is insurance coverage too. So in addition to what you want your cycles to be like or what kind of symptoms and side effects you're willing to tolerate, is your insurance company going to cover it? These new birth control pills, the access plans here, Medicaid plans, they're not going to cover it. So you have to take that into consideration too.
Well, thank you so much. That was so informative. And I think that our patients at Norterra will find it interesting. And it was a very good overview of the anatomy and physiology and how these different options work in the body. So thank you so much.
Yeah, no, you're welcome. Anytime. Happy to help.
Thank you. Thank you for your time and your experience and expertise. We really, really appreciate it. So have a great rest of your day.
All right. Thanks. Take care.